Okay, welcome to the MaineMOM Echo from May 14th. We are really happy to have all of you here. Ashley is standing in for Mariah today, so thank you so much. And we're really grateful to your support. If you have any tech issues, please chat us and we can try to fix it if we can. Okay, so we'll just go through these slides really quite quickly. I think many people know them. And it really is to just help us get oriented here briefly in the ECHO methodology. Ashley, you can go through these. Oh, first, our faculty members. Thank you so much, all of our faculty. This is changing up a little bit as people kind of time out, if you will, from their amazing commitments that they've made. So once Mariah is back, we'll get this updated and have the new faculty list for the rest of our series. You can go through the next slides. So today we're really excited to have Elaine O'Connor, who is our MaineMOM clinical advisor, present on cannabis use during pregnancy. And then we have a really interesting case from Midcoast that Maggie Jansen and Brittany Merrill will bring forward. And I think the slides that are forthcoming, really about the ECHO process. So just a reminder that ECHO is a learning methodology. It's an all teach, all learn methodology. So the hierarchy we really want everybody to feel comfortable participating regardless of your kind of role within the clinical teams. And I think we've been doing a really good job on that. So to facilitate that, it does help to have cameras on, to have the active engagement with people in the session. Please mute yourselves if you have background noise, if you're not talking. And then just let us know if you have any tech issues and we'll carry on forward. And we're, as usual, Maine Medical Association is doing the CME. And Mariah is the lead contact on that. And those are offered for each session. Okay. There. Elaine, if you're all set, we're going to turn it over to you.
I am. Can you hear me okay?
Yep.
Yes. Okay, perfect. So I'm here today to talk to you about cannabis use. I actually want to talk to you during pregnancy and postpartum. I added a couple extra slides because I think that's something that we're all dealing with as well. Was really fun to put this together. I think this is one of the most common questions people ask, and I hadn't actually done a lecture on this topic and that I recall, so it's been at least 5 or 10 years, so it was good to look through the data again. So we'll go to the next slide, please. Okay, so cannabis is the most used illicit drug during pregnancy. So I put it in quotations because there's sort of this ongoing question of illicit versus non-illicit versus legal versus basically medical marijuana cards. I'm not going to get into sort of the politics as much on that side of things because I really treat it the same when I'm taking care of patients. People will come in and say, well, I have a medical marijuana card, and I say it a little bit more gracefully than this, but I don't really care. Basically, the impact is the same either way. I've never prescribed a medical marijuana card. I never will. I think there's a very, very small number of uses potentially, like for, chronic nausea associated with cancer pain, but I see a lot of it done for psychiatric illnesses, and that's not at all studied or accurate. So it is the second to alcohol overall. So if you look at sort of substances used during pregnancy, it falls behind alcohol, which I think was sort of eye-opening to me because I think we don't capture that well enough. You look at a variety of different studies. The frequency of use varies from sort of 2 to 5% at the low end up to almost a third, depending on the population being studied. Up to half of those that use cannabis prior to pregnancy continue to use it during pregnancy. There was some very interesting data on the COVID-19 pandemic and the impact that had actually on prenatal cannabis use, and they're using it more. So it's up about 25% when compared to the 15 months prior to the pandemic. Super common in women who have other use disorders. So there's a nice paper on that topic. I think we see this all the time, certainly. We do see some pure cannabis use, but a lot of our patients with other use disorders. So cannabis use in pregnancy with women with OUD is close to half. With alcohol use disorder, also about half. And with OUD and AUD, also about half. So pretty common amongst folks with other use disorders. It's highly lipophilic and is distributed rapidly through the brain as well as to the breast milk, which we'll talk about. One thing to really note is that both the regulated and illicit cannabis supply has become much more potent over time. You sort of see this, in the news, it's not your mother's whatever, not cocaine, not your mother's pot or cannabis, because it was a lot less potent when people were using it sort of in the 70s and 80s, and it's become increasingly potent over time, and that's true of both markets. Next slide, please. So it's readily absorbed through the lungs and the GI tract. The half-life is about 20 to 40 hours in occasional users to many days in heavy users. And it can take up to 30 days to clear from the system of heavy users. Up to 1/4 of those who test positive for cannabis at delivery actually meet the criteria for a cannabis use disorder. So just as a reminder, that's somebody who wants to cut back but can't cut back. It's having social implications. Maybe they're engaging in risky behaviors like they're smoking cannabis and then getting in the car and driving, things like that. So I think what that really highlights to me is that the use is serious and severe and common. And so this is an issue that we need to be talking to all our patients about. As always, when you're trying to look at very specific effects of cannabis use during pregnancy and postpartum, it's difficult because of all the confounding variables. So sometimes you have to try to tease out the other substance use. Sometimes it's things like poverty or nutrition or concurrent tobacco use. So those can affect the results. I would say there's more pure cannabis information than there is for a lot of other things because a lot of women are just using that. But again, it is more common actually in urban areas, amongst pregnant patients in urban areas, low income, low education. So some of those things do sort of overlay. It's also subject to recall bias. So as with most things in pregnancy, we sort of ask people, hey, did you smoke during your first 30 days or 3 months or whatever? People sometimes don't know they were pregnant. They don't remember what they were doing. It's also one of these things that people are probably less willing to report because of fear of child welfare involvement. So I get into that a little bit as well. Next slide, please. So the impact of in utero exposure to cannabis. So this actually comes from ACOG's most recent committee opinion, which was actually in 2017, which I was a little surprised it hadn't been updated since then. But in animals, THC exposure during pregnancy disrupts brain development and function. That's pretty clear. And then there was a number of studies that were included in that paper that looked at children exposed to cannabis in utero that had lower scores on visual problem solving, visual motor coordination, visual analysis, relative to those that were not exposed, also associated with decreased attention span. At that time, it did not look like it was associated with any anatomic defects, and I wasn't able to find anything that suggested differently more recently. There was some evidence that stillbirth was increased in pregnant patients who use cannabis, and heavy users are more likely to deliver low birth weight infants. There did seem to be this dose response. So what I mean by that is that the more you use, the more risk that you have to have a poor outcome. So between smaller birth lengths and head circumferences, so the more cannabis people use, the smaller the head circumferences of the child. The clinical significance of that was sort of unclear. But there's a lot more data that's come out recently, and I think the important thing to remember is that we're getting better data and the THC levels have increased, so we're actually seeing probably the more realistic impacts of what we're actually seeing within our patients. Next slide, please. So this was a very recent study that actually literally just came out like a month or two ago, and I thought it was incredibly compelling. So it was looking at prenatal cannabis use and the risk of ADHD or autism spectrum disorders. It took a number of studies and did a systematic review. It was a very well done paper with excellent methodology. Included 14 primary studies, so that means there were sort of 14 of their own studies included in this meta-analysis, 10 on ADHD and 4 on ASD. With a total of over 200,000 participants, and really underscored that there is an increased risk of ADHD symptoms and autism spectrum disorder in folks who are exposed to prenatal cannabis. I think that, I find this can be a very effective tool. Well, it can be an effective tool if there's interest in cutting back on cannabis use, because I think a lot of the women that we take care of are using substances because of untreated mental health disorders. So the idea of, I think, potentially increasing the risk of their children's mental health disorders is often an effective way of having conversations with patients. All of this was adjusted for all the other things that we typically see as confounders. So this was a pretty substantial study, which I think, I would have no problem using this information and talking to patients and feeling good that this is pretty accurate. Next slide, please. I absolutely love this. This comes from, and I can mark it in the references, it comes from it's like Up in Smoke or something reference. It's from Canada. Clearing the Smoke, I don't know, you see it on my reference list, but I cut and paste it directly from there. I really like this. So this is looking at all the studies that have been done and specific to the age group of the offspring. And so, like the increased risk of adolescent substance use amongst people who are exposed to prenatal cannabis. So really throughout the whole lifespan of, small children and adolescents and even into early adulthood. I personally think this would be great to hand out to patients, not to scare them, but to just make sure they have good information about the potential impact of cannabis use. And I find it very accessible because you can really see them by age. So I like this slide a lot. Next slide, please. So I think the most important question, is why do pregnant people use cannabis? Because that's really the conversation you're having with patients. So there's a pretty strong perception that there's no risk to regular cannabis use. And it actually has increased about threefold amongst reproductive women during that 10-year period. So people are actually perceiving that there's less risk, even though we're probably saying there's a higher risk because of the potency of the cannabis. Up to 70% of those surveyed in one study believe that there's a slight or no risk of harm from using 1 to 2 times a week while pregnant. As I mentioned earlier, those that live in urban areas, those who are younger with lower income and education, tend to use more cannabis than their counterparts and also are less likely to view it as dangerous. So we see a lot of women, and there were some interesting studies, and I kind of clumped them into sort of why do people use, and some people use it for what they sort of clumped it into health management. So that's people that are nauseous, having morning sickness, pain, challenges, sleep difficulties. Some people turn to it when some people turn to cannabis when providers stop psychiatric medication. So I think something, again, to always be thinking about, we don't want to stop people cold turkey on whatever it is that they're taking because they may sort of pick up something that's not very healthy. They also will often use it to sort of stop using what they perceive to be more dangerous substances. So some people will try to use cannabis to get off of opioids, or there's sort of this like substitution effect where they'll I see this with alcohol and other things, that they're sort of cutting back on opioids maybe, but they're increasing their use of other substances. And there's a perception amongst those interviewed that when you use it for health management, is often believed that cannabis is actually safer than prescribed medication. So, people who say, well, I take it for anxiety and, it's better than an SSRI, like that is really clearly not true. And I think that's an important place to educate patients. That's believed true, like we talk about Zofran and other things as well. So important to talk to folks about how it's probably a lot less safe. But again, I think the fact that it's legal and other things has kind of complicated the issue. I think the fact that people are confused about this whole medical card thing, I too would think something is safe, right, if people are prescribing it. So it's confusing for patients. And I think there's a lot of inaccurate information out there. Next slide, please. So there was sort of another kind of clump of reasons why people use it, and some women use it for sensation seeking. So just sort of trying to feel better. They're dealing with life. Anxiety kind of fell into both these categories, but really it was amongst a lot of women who had like other little kids running around at home and they're pregnant and life is chaotic and it's stressful. And so I smoke pot at night to tolerate life, basically. Patients often do not disclose it for fear of CPS reporting, stigma from providers. So that's true of all the substances we probably see during pregnancy, but this is probably a pretty common one. Patients also report that they get very mixed messages from providers. So there's both like inaccurate information that they're getting, and other providers just don't talk to people about it at all, which I'm sure happens all the time, right? They don't ask, they don't get the information. Many women felt that they were not given adequate education to make an informed decision. So that's really our job, to be able to give them that information to help them make the right decision. There was a very interesting study that looked at kind of where is the most reliable source of information for patients. And I found this a little bit horrifying, which is why I underlined it. So patients said that basically the internet and online literature was the most reliable source of information. Healthcare providers were actually not the preferred source of information because we don't talk about it clearly and they're sort of fearful of raising it with us. So I think, again, more evidence that we need to be able to provide clear messaging on this topic. And I see it all the time, where people are being told different things. It's fine to use during pregnancy, but stop before breastfeeding, like stuff that just doesn't make sense to me at all. But I think few patients are being told that. So it's our job to make sure they're getting accurate information. Next slide, please. I like this little study, which just kind of took people by sort of where they were, kind of pregnancy or pre-pregnancy, pregnancy, and lactation, and kind of tried to sort of clump them into kind of why are people using. And I think that was, sensation seeking tended to be less common during pregnancy, more pre-pregnancy and during lactation, and sort of symptom management was really common in pregnancy. And then there was some sort of overlap, right? So coping and symptom management, the 17 in the center could very well be sort of anxiety and stress and poor sleep and things that you might see going with pregnancy in general. But I thought this was kind of an interesting diagram. Next slide, please. I don't know what the top of that slide says. Something about what about cannabis use during pregnancy reporting to OCFS? So that would be the elephant in the room today. That really depends on who you ask. I mean, that's the honest answer. I think there's a lot of hospitals that don't report cannabis use. But if you ask any OCFS leadership, they absolutely say we want to know everybody who's, they deem that to be a substance exposed infant and we want that reported. I don't really have a position on this topic, just know that it's inconsistent. I think what I talk to patients about is that, is it one of the many variables that will tip the scale for a report? So sometimes we'll see somebody who is only using cannabis. We're able to document that they're only using cannabis in terms of their drug screens and their history. But maybe there's other issues in the home. Previous children have been removed, or somebody has a criminal history. So sometimes I think it does become one of many things that kind of tips the box or tips the scale into reporting. So I try to counsel patients about that. We're discouraging its use, and if you're continuing to use it, that may be, somehow sort of included in the decision whether to report or not. I put this picture in because I just want to also say that remember that if there's little humans in the home, like cannabis looks like gummy bears, and I mean those things in the middle look really tasty to me. And they look really tasty to my kids when they're crawling around on the floor. So just safe storage is hugely important. I think in particular, you hear about these things where kids go home and they eat a brownie and they didn't know it had cannabis in them. And then they get really sick. I mean, this is something that we absolutely see childhood ingestions resulting from, which you can totally appreciate. I mean, I would eat 6 of those candies if I were 6 years old. And I would have a lot of problems after that, right? Even as an adult, I'd probably have a lot of problems. So just safe storage is hugely important. Next slide, please. So what about the impact postpartum? So this was a very interesting paper that came out of California that I wanted to for sure include. So it looked at more than 34,000 births with cannabis use disorder. So this was specific to cannabis use disorder. So there was a problem in the chart that was cannabis use disorder during pregnancy, and found that the incidence of infant death in the first year of life was 1.4 times higher amongst infants who were born to those with maternal cannabis use disorder when compared to those born to folks who did not have that. When examining the specific causes of death, there was this increase in sudden unexpected infant death, so sort of unclear cause. And when you looked at it, the bottom bullet, there was no increased risk of infant hospitalizations or ED visits. So these were not necessarily sick kids that were going to the hospital. These were kids that ended up dying kind of unexpectedly. Probably the secondhand smoke exposure was a factor. I worry a lot about impaired breastfeeding. I'm part of the maternal fetal infant mortality review panel. We talk about people who fall asleep and are impaired while breastfeeding and end up smothering the children. And then unsafe sleep, when you look at the infants that die in the bed with their parents, the co-occurring substance use disorder, whether it's cannabis, opioids, or anything else, is very, very high. You can imagine if you're using a lot of cannabis, it's going to impair your coordination, your ability to wake up, your ability to respond appropriately to cues. So I think this is a high-risk situation that you really need to talk to folks about. And again, they may not be smoking, they may be eating whatever cannabis-containing products. So I think this is a really important conversation that patients understand there is an increased risk. Next slide, please. Okay. Breastfeeding also increased amongst cannabis use has increased amongst breastfeeding women. concentration of THC in breast milk may exceed maternal plasma concentrations because of the high lipophilic properties. Peak concentrations in breast milk occur about 1 hour post-ingestion, and it has a long half-life, as I already mentioned, take weeks to clear. There's very limited data if you just specifically look at breastfeeding as a risk. So if you have somebody who maybe stopped using cannabis during pregnancy and then started up again during breastfeeding, there's limited data sort of looking at that long term. So that's hard to say that just during breastfeeding is a risk. The one thing that was interesting is that if you look at the risk of, what do you do when somebody's smoking cannabis and they're breastfeeding? And it actually seemed that the risk from exposure to cannabis in the breast milk offset the benefits of breastfeeding, basically offset some of the risks of secondhand cannabis smoke in terms of the risk of sudden unexplained infant death. So if they're getting exposed to secondhand smoke, that it's probably better to recommend that they're breastfeeding, which I kind of sat with for a while, but that was what the literature was pretty clear to recommend. Again, we're not endorsing the use of cannabis at all, but if they're just being exposed to secondhand smoke from cannabis, it's probably better. The benefits of breastfeeding in terms of the immune response and lowering the risk of some sudden unexpected infant death is probably benefits or probably offsets the risk. So an interesting point. Next slide, please. That might be the last one. Okay, so summary, cannabis use during pregnancy and postpartum is increasing with associated adverse outcomes. Important to discuss this issue with patients in a non-stigmatizing, non-punitive way. I think preconception counseling might be the ideal time, right? Because people are not necessarily wanting to disclose it during pregnancy. And so really having conversations about cannabis use in women of childbearing age, particularly if you're thinking they may become pregnant, it might be the ideal time to have that conversation. Maybe you can have a more open conversation because they're not worried about that CPS referral. And I think it's just really important to know your facts so that patients can make informed decisions. I mean, I sort of found it horrifying that they didn't view healthcare providers as a good source of information on this topic, because I like to think we are. But we don't really want patients to rely on online literature, because we all know the quality of online literature is very mixed. Whether it's even literature at all, who knows? It could be Dr. Google or whatever. But so important to know your information. There's some great references which we will send along that are, I have 3 pages of references for those who are interested. I think those are my next slides. So you can, I think that's the last one. Yep, perfect. Oh, that's the one though, the Canadian Center for Substance Use and Addiction, clearing the smoke on cannabis. That was the one that had that really cool slide with the kids of different ages. So if anybody wants to actually print that out, that's the one that had that. Great, questions? I talked fast. Also a little weird to talk to a group of people and then also have people on the screen.